Hello, it's a pleasure to be here today and to have the chance to share some of our experiences in managing COVID-19 in Canada in this session. Over the next couple of minutes, I'll give an overview of the rollout of COVID-19 therapeutics across Canada, highlight some helpful resources, and walk through a couple of interesting cases highlighting some challenges. Now, it seems like a long time ago, but if you recall, at the beginning of the pandemic, one of the repurposed drugs being studied for treatment of COVID-19 was the HIV protease inhibitor, lopinavir-ritonavir. We found that during the first wave, 141 patients hospitalized for severe COVID and who were screened for treatment with lopinavir-ritonavir in the CATCO study, that over 90% of patients had at least one potential drug-drug interaction with lopinavir-ritonavir, with a median of 4 red or amber DDIs per patient. You can see that this was a somewhat older and sicker population with multiple comorbidities and co-medications. And over 1/3 were considered ineligible for the study upfront due to potential drug-drug interactions. In our centers, it was often HIV pharmacists who are redeployed to support screening and DDI management of these patients, given our familiarity and experience in managing interactions with boosted protease inhibitors. 2 years later, nirmatrelvir-ritonavir or Paxlovid was approved in Canada, and once again, we needed to manage interactions involving ritonavir. However, as we know, there were some significant differences this time around. First, with a focus on treating patients on an outpatient basis to prevent progression to severe disease. The oral formulation and short treatment course also made it a more attractive option to use in smaller centers and rural areas. These differences had both positive and negative impacts on delivery of treatment and management of patients. Now, in Canada, there are federal standards for healthcare as per the Canada Health Act, but it's the provinces and territories which administer and deliver most healthcare services. As such, each province has had its own system for rolling out treatments such as Paxlovid, with differences in how or where patients can access treatment, depending on prescribing authority or scope of practice, infrastructure, and resources. In some provinces, nurses or pharmacists may prescribe Paxlovid as a delegated health act, although Ontario, where I work, is not one of them. In Ontario, clinical assessment centers can test, assess, and provide treatment options for COVID-19, including Paxlovid, IV remdesivir, and monoclonal antibodies. Once a patient presents at a clinical assessment center, blood work is done, a physician approves the prescription, and a pharmacist does the medication reconciliation, DDI assessment, and dispenses the medication. Follow-up is then done virtually by a nurse or pharmacist. Paxlovid can also be prescribed by any physician or nurse practitioner and is dispensed by participating pharmacies across the province. Given the large geography, many remote or small rural sites are serviced by telehealth or virtual pharmacies. Now, these different models can lead to potential gaps in access and care. For instance, most physician offices have limited hours and are closed on weekends and evenings. In many provinces, health and pharmacy records are not centralized, so it can take additional time to obtain important medical information or complete prescription histories. And depending upon patient complexity, identifying and managing important drug interactions can be very time-consuming, particularly if there's a need to consult other prescribers. In our institution's assessment center, of the first 211 patients assessed, the majority of patients did receive Paxlovid. And in general, these patients were younger, with an average age of 64 and 7.8 co-medications, compared to the patients we saw in Wave 1. Less than 30% had complete medication records accompanying their initial referral, and close to 60% of interactions involved drugs which are not identified on the initial referral form. At another Toronto assessment center, of the first 256 Paxlovid prescriptions, 1/4 required a renal dose adjustment. 71% of patients had at least one DDI identified, and most were managed by holding the medication, while 1/4 required dose adjustment. On average, it took pharmacists at either center approximately 1 hour per patient to do all the work necessary to review the referral, complete the best possible medication history, do the drug interaction assessment, contact prescribers, counsel the patients, and complete documentation. So the challenges in rolling out Paxlovid can be even more significant in rural or community pharmacy settings where healthcare providers can be more isolated or understaffed, where they may need to juggle multiple responsibilities, for instance, in a busy retail pharmacy setting, or who may have less experience managing complex DDIs. And sometimes there can be a delay of 1 to 2 days before a prescription is approved or delivered because of the time involved in gathering information and contacting prescribers. Paxlovid is provided free of charge to patients, and pharmacies are reimbursed a dispensing fee of $13. For these reasons, not all pharmacies choose to have Paxlovid available, and in some cases, Paxlovid may not be prescribed due to DDI concerns by the primary prescriber. In Ontario, the Science Table created a number of resources for prescribers and pharmacists to support Paxlovid prescribing. And we also encouraged people to refer to the NIH guidelines and the University of Liverpool COVID interaction website. During this time, a group of pharmacists from the NIH, the University of Liverpool, and Ontario started to meet regularly to discuss challenging DDI scenarios. And this was great for sharing knowledge and also ensuring consistency of information between these different resources. Numerous education sessions were also held for family physicians and pharmacists to familiarize them with how to safely prescribe and dispense Paxlovid. One key strategy was to do as much preemptive work as possible, such as identifying higher risk patients, getting relevant lab work done, completing a complete medication list, and working out an interaction management plan in advance. Patients were counseled on what symptoms to watch out for and the importance of following through within the necessary time frame. Some physicians would give prescriptions to keep on hold at the patient's pharmacy. Things that were much appreciated by pharmacists included writing down a patient's creatinine clearance on the prescription in case dose adjustment was required, and also to have the physicians write their cell phone number rather than an office number on the prescription in order to facilitate quick communication. Here's a case of a 62-year-old male living with HIV since 1996 with hypertension, diabetes, or hypertension, dyslipidemia, and type 2 diabetes. He has a history of intermittent antiretroviral therapy and was most recently on elvitegravir, cobicistat, emtricitabine, and TAF with viral suppression, but discontinued this over the pandemic and was lost to follow-up. He recently presented to hospital with seizures and a brain lesion, a low CD4 count, a high viral, and was diagnosed with CNS toxoplasmosis. He was started on dexamethasone for 4 milligrams every 6 hours, trimethoprim sulfamethoxazole, and an anticonvulsant. The patient was stabilized and discharged, and the plan was to have him seen in clinic to restart his antiretroviral therapy. However, his serum creatinine jumped, and the physician wondered if the acute kidney injury was due to trimethoprim sulfamethoxazole. Upon further discussion with the patient, he reported experiencing a sore throat for a few days with very limited oral intake. And he then tested positive for COVID and was considered a candidate for Paxlovid treatment. So to summarize, the clinical issues and priorities for this patient include the following. Treating the CNS toxoplasmosis and continuing to use adjunctive corticosteroids for a few more weeks. For HIV, he needs antiretroviral therapy due to his low CD4 count and high viral load. And his advanced immunosuppression also does qualify him for COVID antiviral therapy. Finally, with his diabetes, the dexamethasone was making glucose control more of a challenge. So his metformin and sitagliptin dose was increased to 1,000 milligrams and 50 milligrams twice daily. So when considering potential drug interactions, keep in mind that dexamethasone is a CYP3A4 substrate and inducer. Metformin is an OCT2 substrate, and many antiretrovirals, as well as Paxlovid, are substrates and inhibitors or inducers of CYP3A4, P-glycoprotein, and other transporters. With dexamethasone, the extent of induction depends on both the dose and duration of treatment. This framework by Jacobs et al. Suggests that dexamethasone, when used for COVID-19 treatment, can be considered a weak inducer due to the low dose and short duration of therapy. But when used as adjunctive therapy for toxoplasmosis, dexamethasone is considered a moderate inducer due to a higher dose and longer course of treatment. Therefore, for this patient, we need to consider, first, Paxlovid might increase dexamethasone concentrations, which may be significant as he is already experiencing side effects of dexamethasone on glucose control. And since the higher dose of dexamethasone is being used for a more extended duration, there may be potential induction of metabolism of various antiretrovirals. And here, dolutegravir may be a preferred choice compared to other integrase inhibitors or non-nucleoside reverse transcriptase inhibitors. A quick reminder that antiretrovirals can be continued with dose adjustment while on Paxlovid therapy due to the short duration of treatment and excellent tolerability of modern ARBs. And we should also keep in mind that metformin concentrations can be increased by some integrase inhibitors, with dolutegravir having a more significant effect compared to bictegravir. The dolutegravir product monograph recommends limiting metformin to 1,000 milligrams a day when starting therapy. To wrap up the case then, the patient was prescribed Paxlovid for 5 days for his COVID, and his dexamethasone dose was reduced by 50% during this time. Antiretroviral therapy was initiated with dolutegravir plus tenofovir DF and emtricitabine in order to avoid concerns about the negative induction effects from dexamethasone, and his metformin dose was reduced. The patient recovered from COVID. His dexamethasone was tapered off after 1 month, and his antiretroviral therapy was subsequently switched to a bictegravir single tablet regimen for improved adherence, and his glucose remains well controlled on the lower dose of metformin. And to wrap up, the second case involves a 65-year-old male, virally suppressed since the mid-2000s. Comorbidities include hyperlipidemia, benign prostatic hypertrophy, osteoporosis, and acute lymphocytic leukemia. He is on a non-boosted antiretroviral regimen consisting of a bictegravir single tablet regimen plus doravirine and moravirine, along with a number of other co-medications. In March, he reached out to me to ask about what potential interactions he should be concerned about, just in case he developed COVID down the road and needed treatment. We recommended that if this were the case, his antiretrovirals should be continued. His rosuvastatin and tamsulosin could be held, or the tamsulosin could be given every other day if he experienced rebound BPH symptoms. For dasatinib, we suggested either holding this medication for a week or decreasing the dose while on Paxlovid. The patient booked an appointment with his oncologist to discuss these two strategies, and the oncologist recommended that the dasatinib be held. A few months later, the patient did in fact develop COVID and was prescribed Paxlovid. And because all of the drug interactions had been discussed ahead of time, he was able to start treatment with no delays, and the treatment was effective at keeping his symptoms extremely mild. So in summary, there are numerous systems for rolling out Paxlovid with differences between provinces and between various settings. Common barriers include a lack of centralized health and medication information, drug interaction complexity, involvement of multiple prescribers, and healthcare provider workload models, which may not support the intensive time required to prescribe treatment. Resources to support Paxlovid prescribing and DDI management have been very well received across the province. And patient education and advanced planning have also been very helpful in helping to ensure timely access to medication. Thanks for your attention.